It's River to River from IPR News. I'm Ben Kiefer. Coming up later this hour, I'll talk with gerontologist Elaine Eshbaugh of UNI. She'll share the connection between anxiety and dementia. But first, two University of Iowa dental experts have recently been recognized for their work expanding dental care access to Iowans who often fall through the cracks. People with disabilities, older Iowans in nursing homes, and low-income residents in rural communities. Later in the hour, we'll hear from John Warren about a federal grant aimed at improving dental care access for low-income Iowans. First, though, his colleague, a conversation with Dr. Leo Marchini I had yesterday. Dr. Marchini is a professor and chair of the Department of Preventive and Community Dentistry at the UI. Dr. Marchini was just appointed to the Scientific Committee of the International Association for Disability and Oral Health. That's a recognition of his work bringing dental care directly to nursing home residents through the UI Dental College's Geriatric and Special Needs Program. He was also named a 2026 Health Access Hero by Sun Life. Dr. Marchini, thank you for coming into our studio. What a pleasure to have you, and congratulations on these two honors.
Well, the pleasure is all mine, Ben. Thank you for having me. Those honors reflect the work of a great team. It may bear my name, but in actuality, it is just a recognition for the amazing team that we have right here in Iowa City.
In plain terms, tell us what you actually will be doing on this committee. What does discussing the best ways to address oral health for patients with special needs look like in practice?
Yes. When you think about patients with special health care needs, we have a very heterogeneous group, right? We have a group of people who involves, kids with special health care needs, adults with special health care needs, and older adults who become dependent and have special health care needs. So when you think about the kids with special health care needs, they get great care from pediatric dentists. Pediatric dentists are advanced trained dentists who have special skills developed to treat kids and kids with special health care needs. And most states across our country provide excellent coverage for dental health for kids with special needs. However, when these individuals become of the age of 18 and become adults, some of those protections fade away and they don't have as much care, and pediatric dentists may not see them anymore. So that's when we need to plan for the transition of care for the kids with special health care needs, now adults with special health care needs, so they don't fall through the cracks of our system. And to do that, we need to prepare the future workforce to be advocates for this population and provide the care they need. So in that committee, we discussed that in international level. How are the curriculum guidelines to teach the future workforce on the best ways to advocate, prevent oral health issues, and treat oral health care issues when they arrive to that very special and vulnerable population.
Mm-hmm. When you look at this population now, whether it be in the U.S. or worldwide, what are the greatest gaps, the greatest needs to fill there, more specifically?
The most important need is to provide continuity of care. What do I mean by that? I mean having frequent care, having preventive care provided at their homes, right, by their caregivers, either family or paid caregivers, should help them when they can brush their teeth and floss. And if they cannot do that, they can brush and floss for them appropriately, effectively. So that level of domiciliary care is the first gap to be addressed. Then after that, they need to have that regular cleaning, that you and I have every 6 months or so. And we come for a cleaning and a regular, examination. Yeah. Sometimes a radiograph. Yeah, that population also needs that. But as they have special needs, as they may need a chair that accommodates their physical disability, or they may need a room that accommodates their sensory needs, they have a little bit more of a difficult finding a provider that takes care of them. So we need to have more frequent ambulatory care, regular care for that population too. When those two first and most important steps are not present, what happens is that they develop auto disease. Auto disease, Ben, are, chronic conditions with occasional flare-ups, right? So when someone has a toothache, it's because something has been going on the wrong side of things for a long time. And they may have multiple other problems that are not acute at the moment, but may become acute in the future. When they reach that level, they may not be able to be seen in the regular dental office anymore because their needs are so great, and and the need for special accommodations will not reach the level that can be provided in the regular dental chair. So they may need operating room care. They may need care under general anesthesia. And that becomes much more difficult because operating room time is of high value. And as you can imagine, in the operating room, they have very important priorities, people who are with life-threatening conditions or conditions that can't wait, or, conditions that can bring much more morbidity than no conditions. So we compete with those conditions for the care for this vulnerable population, and what happens is that care is usually delayed by many months sometimes.
For those who've just joined us, I'm talking with Dr. Leo Marchini of the University of Iowa College of Dentistry about dental care access for people with disabilities and older adults. Let's give a good example here, because you've shared that your son, you have a son with autism. So your son
That's
falls
right.
in this special needs category. I understand he's about to turn 16, which means, Dr. Marchini, he is approaching that same cliff you just described, where systems built for kids stop applying. Tell us about someone with autism and how that is a special needs group when it comes to dentistry later on.
So absolutely. My son is now 16, and he was diagnosed with autism at the age of 6. And ever since, he has been seen by the wonderful team of pediatric dentists that we have at the College of Dentistry. And that care has been spotless. Every time he needs, his cleanings, he has his cleanings done at the Center for Developmental Disabilities, the CDD, that's right next door to the Dental Science Building, and by specialized professionals who care with him with a lot of love and empathy. And once he needed an operating room procedure because he had a trauma to his front teeth, and then that care was provided in a reasonably timely fashion and all that, because he is under that pediatric care. Now that when he becomes 18 and he becomes an adult, he may need to continue that care. And here in Iowa City, that's not so difficult. He will transition from the pediatric dentistry clinic at the University of Iowa College of Dentistry to the the geriatric and special needs clinic in the University of Iowa College of Dentistry. So we'll transition him from one clinic to the other, and he will get the care he needs there. Now, when you go to rural towns where you have one pediatric dentist there, but you may not have a general dentist who see people with special health care needs, that care finds a barrier. And that family may need to travel long distances to either get to our geriatric and special needs clinic. We see patients from all 99 counties of Iowa. Or they will need to go to a community health center or a pediatric, or some pediatric dentists keep seeing their patients for longer, but not much longer because their offices are all prepared for kids, right? So that's an example on how things can, fall through the cracks in the system.
I understand now how when you age into adulthood, that things become more difficult, and then you put off cleanings and this regular dentistry that's so crucial until it becomes something acute. So let's talk more about the environment for special needs and what's being done about that when we come back. We'll be back with Dr. Leo Marchini from the University of Iowa College of Dentistry, talking about dental care access for people with special health needs. It's River to River from IPR News. Back with more River to River from IPR News. I'm Ben Kiefer, talking right now with Dr. Leo Marchini of the University of Iowa College of Dentistry. A recent conversation I had with him about dental care access for people with disabilities and older adults, and why turning 18 can mean falling through the cracks of the system. I want to have a picture, a more concrete picture of what a visit looks like for a patient who can't easily adapt to a dental office. What are you and your team doing differently in that room for special needs people?
People need to adapt to the environment, right? They go to the dental chair and they need to sit there, stay with their mouth open. Sometimes what they are doing in their mouth is not the most pleasant thing. It might be a little sensitive here and there. You may feel a little bit things happening, sounds, noises, and things. And you don't have control over the situation, right? You have your mouth open, someone is working in there, you have trust, you have developed a relationship with the dentist, you know what to expect from previous experiences, and your brain is processing all that. All right, now, when we have patients with special health care needs, say that with a cognitive impairment or with intellectual disability, they may not process the same things the same way we do, and they may have limited capacity to adapt to the environment. So we need to go in the other direction. We need to make the environment adapt to them, right? So we change everything on our end that we possibly can to make that experience easier to adapt to them. So what we do, say, a patient who has sensory issues, we dim the lights, we use different lighting, we use a focus of light that's a little smaller so it doesn't reach their eyes so easily. We give them sunglasses, right? We provide them with some fidgeting gadgets so they can have something to distract them. We have monitors with preferred cartoons or preferred movies going on to them. So we need to know them well, so we know their preferences, and we can adapt the environment to them to make it very friendly to them. We know how to talk to them in the way that's meaningful to them, right? It's not a meaningful conversation to anyone. It's a meaningful conversation to them. So
doctor, you are actually trying to understand what it's like to be in their shoes, experiencing what is the normal everyday thing for you, but for them, it's something perhaps very scary, right? And in their environment.
Right, very scary because they don't know what's going to happen, right? And if we explain it to them, it may scare them even more. Yeah. So depends on each patient, right? We adapt it to them. So say sometimes we use weight blankets, right? They like that extra weight over them, gives them a sense of, protection. Some people don't like it. Some people would need a few extra pillows and some blankets to help them feel more comfy in the chair, and that provides them with a good sensation, much more comfort.
Dr. Marchini, what about the older population? Let's talk about some of the common adaptations you need there, the special needs for older population. I mean, what springs to mind is what we're talking about later this hour, older population with dementia there. I imagine depending on the degree of dementia you have, getting dental care could be very tricky.
You are absolutely right, Ben. It can be really tricky. Let's start from the beginning. Imagine a family that's going to their primary care provider, and the primary care provider starts to be suspicious about some memory loss, right? And then they go over a few tests and a few more exams and things, and they interview with the family, interview with the patient, and they get to diagnosis of Alzheimer's. That's a pretty important diagnosis to the whole family, right? Mm-hmm. Now, when that happens, it would be ideal that our friends in medicine would be able to tell them, among a zillion other things that they need to cover in that appointment, the importance of going to the dentist. Because if they go to the dentist in that early moment, in that early phase of the dementia journey, we would be able to establish a preventive routine to avoid the consequences of oral health deterioration, right? So that is key, because we can start to provide them with home routines, but also routines in the dental office, get them used to the dental office, to a new dentist that cares for that population, and establish that trust and that routine, because then it's much easier for them to transition into oral health care. Now picture that as the ideal situation, right? So we will be able to use prevention, and we will never have an acute episode, right? Mm-hmm. Because we prevent it.
Yep.
Now, what happens more often than we would wish? Our patients don't get that early advice, and what happens is that they go without care for many months, years sometimes, because nobody even noticed that they are not brushing anymore. And when they would get to notice it is because something really bad happened. They have a pain, or they have an abscess, or they have infection, they have something that is acute. And when they go do an exam, their oral health has already deteriorated. Now they need extensive care, and they are not even used to the dentist, because that would be a new dentist to them, because it's a dentist who is specialized in older adults with special healthcare needs.
Mm-hmm.
So then we need to gain that trust in a time when it's very difficult for them to establish new relationships and all that. We have techniques to do it, but it's much better if we go the preventive route, right?
Yeah, I get a sense of what you're facing and the gap that the needs that you're filling here. Your clinic at the University of Iowa, I understand, has thousands of visits a year from all 99 counties, more dental schools starting a program to model theirs after yours, because I think accreditation now requires it. In the closing moments here, does that all give you hope that it gets easier for the next generation of patients with special needs?
Yes, absolutely. We train all our Iowa grads into the geriatric and special needs rotation. They spend 5 full weeks with us every day seeing patients with special healthcare needs, older adults with dementia, adults with intellectual disabilities and physical disabilities as well. And they are going to be in our communities in the near future providing care to our families. And I am sure, because they're so wonderful students, that they are going to be even better in providing that care than we are at the University of Iowa College of Dentistry.
Very quickly, before we say goodbye, Dr. Marchini, if someone's listening who has a family member with special health care needs, dentistry needs, struggling to find dental care, what's the one thing you'd want them to know?
I want them to know that we are here for them and that they should contact us, because even if we cannot accommodate them immediately, we will do the best we possibly can to accommodate them as soon as possible or find care for them close to where they are.
Okay. Thank you very much, Dr. Leo Marchini of the University of Iowa. Thanks for coming in today.
Thank you for having me, Ben. It has been a pleasure. Thank you.
That conversation recorded with Dr. Marchini. It's such an important topic, dental care access for people with disabilities. It's River to River from IPR News. I'm Ben Kiefer. Let's turn quickly to another piece of that puzzle, access for low-income and rural Iowans, with Dr. Marchini's colleague, Dr. John Warren, professor of preventive and community dentistry at the University of Iowa. Dr. Warren, thanks for coming in.
Thanks for having me, Ben.
You've received federal funding to place UI dental trainees directly in community health centers across the state. This is to address some gaps for underserved communities. You've been at the University of Iowa for over 30 years, I understand. You're originally from Iowa Falls, so a smaller town yourself, and your department has always focused on underserved communities. Let's talk about this grant, though. What does it actually do? Where does the money go, and who benefits?
Yeah, so this grant is from the Health Resources and Services Administration, or HRSA. And HRSA, they do a number of things supporting the underserved, like they support community health centers. But in this case, they provide training to dentists and other health professionals so that the workforce out there is what we need in our communities and in low, high areas of need. So our grant is really to place our graduate students who are dentists out in various community health centers for short bursts of time, so our students can learn kind of firsthand the challenges that are seen among the these low-income clinics and in both rural and urban areas in Iowa.
Mm-hmm. Let's talk about those obstacles low-income and rural patients face a little bit more. Struggling just to get appointments, taking off work, transportation, insurance gaps. Are those the main obstacles?
Those are many of the main obstacles. People lack, dentistry costs some money, and if you're low income, you don't have it and probably don't have dental insurance. Something like 70 million Americans don't have any dental insurance. In contrast, it's about 27 million don't have health insurance. So there's many more people who don't have dental insurance. Transportation, as you mentioned, just maybe not having reliable transportation to get to and from a dental office. relying on public transportation, which may not be available in rural areas. And then, as you mentioned, just their ability to get to a dental office, find a dentist who will take their public insurance. It's also important to mention that Medicare, which is for older Americans, really doesn't have any coverage for dentistry. So those are some of the obstacles. So that those are many of them. I guess one other thing is low-income populations tend to have more disease, more cavities, more missing teeth, things like that, which is again a challenge for them, which is sort of a consequence of not being able to have regular dental care.
And I understand that community health centers in rural areas that are multidisciplined, close together, are part of the solution to meeting this. Maybe something like having a social worker helping with transportation. Paint a picture of how that sort of structure may be different in a rural area and be more helpful in getting access.
Right. So if we have some, if there's more coordinated care, so for example, they can come to the community health center, see their primary care physician, and then maybe the primary care physician sees something in the patient's mouth, they can quickly send them over to the dental clinic, and vice versa. So that helps kind of coordinate the care a little bit more. Sometimes the community health centers, like you mentioned, may have staff people who really specialize in making sure people can arrange transportation or deal with some other things. I think a few health centers and places may have some child care so that if they have a child that they're caring for, they can bring them along and not have to worry about finding child care for them while they're attending an appointment. So things like that can kind of work together to solve some of these kind of overriding issues that face people with low income or people in remote areas.
Yeah, and as I discussed with your colleague, Dr. Marchini, there are ripple effects of untreated dental problems. Kids with dental problems struggle to focus in school, difficulty eating, employment challenges for adults who have missing teeth. That goes on. But I want to, in the few moments we have remaining, have you talk a little bit about keeping dentists in underserved areas. How big of a problem is that?
Yeah, that's an issue because dental school costs a lot of money, and so many of our students graduate with enormous amounts of debt, $300,000 or $400,000 perhaps, and so they need to kind of go find places to work where they can make that money back in order to pay off their debt, and in community health centers they pay their staff pretty well, and they also typically have some loan repayments. But once those loans are kind of whittled down or are paid off, the dentist often will go and seek greener pastures. So that's a challenge. Just attracting a new graduating dentist to a community health center where their pay is probably going to be lower. Anyway, that's a challenge.
Is there anything policy-wise that could be changed to address that?
Well, I wish I knew. There certainly, if we could find a way to provide some scholarships or reduce tuition in some way or loan repayments, all those things would help. It's just a very scary thing for our new graduates facing all this debt. And they just kind of feel like they have to go make some money somewhere. So that's just a real challenge.
We have 1 minute left, and part of the funding, I think we should mention here, helps cover tuition so students graduate with less debt.
Right. So so the grant, most of the money goes to our trainees, our graduate dentists who are getting training in public health and rotating through the community health centers. So the grant pays for their tuition, pays them a little bit of a stipend, so they, at minimum, they at least don't incur more debt while they're in this training.
And this program with students who go through community health centers in rural areas, I guess we would hope some of them would stay in those communities, running clinics themselves down the road. That would be a hope. We have to go, but perhaps a brighter future for access in rural Iowa.
We hope so.
Okay, thank you very much. Dr. John Warren, Professor of Preventive and Community Dentistry at the University of Iowa. Thank you so much for coming in.
Yeah, thanks, Ben. Good talking with you.
Good to talk with you. Coming up after a break, anxiety and dementia. They are connected, and we'll find out how. After this break, it's River to River from IPR News. It's River to River from IPR News. I'm Ben Kiefer. Anxiety and dementia. Those are problems we often talk about as separate. Put them in separate boxes, but actually they're deeply connected. And this part of the program, we want to understand the link between anxiety and dementia and how that link could change how families care for a loved one. Joining us now from our studios in Cedar Falls, Elaine Eshbaugh is a professor of gerontology at the University of Northern Iowa, founder of UNI's Dementia Simulation House. That is a space where people can step inside an experience designed to show them what living with dementia actually feels like. Elaine, welcome to our program.
Thank you so much for having me.
I watched your TED Talk this morning. I recommend it to everybody. Pretty much all of us now have friends and family with dementia, and it really gave me some great insights as to how to communicate, how to lessen anxiety in the circle of my loved ones who have dementia. So first of all, kudos for that. I know you've been receiving honors for it. It was selected as a TED Editor's Pick, a distinction given to less than 1% of TEDx talks worldwide. Congratulations on that.
Oh, thank you. I appreciate that.
Let's dig into that connection, what it means for thousands of Iowa families navigating dementia every day. You've coordinated UNI's gerontology program for quite a few years now. 20 years, I think, something like that. You later...
Oh, gosh. Yeah, something like that.
Right. Later, you founded the Dementia Simulation House. Tell us what that is and what made you want to create a physical space where people could experience dementia firsthand rather than just teaching about it.
Yeah, so one of the things that has always bothered me about dementia is people will say to me, my grandma has dementia. It is so hard on my grandpa. And while that's absolutely true, no one really talks about how hard it is on your grandma or how hard it is on the person who is experiencing the condition. So one of the things that, kind of spurred my interest in doing this is also the idea that 4 out of 5 people living with dementia live in their own homes. So we think, people with dementia live in a nursing home. But if they live in a nursing home, it's really at this end stage of this disease process. And most people with dementia are living in the community, going grocery shopping, maybe going to the gym, going to the library, doing things the rest of us are doing. So it's important to me that we have this house setting. So when you come into the house, you put on gear and we show you what it might be like to live with dementia and do typical household chores that we all do, like making your coffee in the morning or Swiffering the kitchen floor. So our goals are to increase empathy for those living with dementia, also educate the community, and empower caregivers and those living with dementia to live their best possible lives.
Yeah. So you mentioned gear. Talk about the gear. What are you wearing? You have things on your hands or eyes or what?
Yeah. So we have glasses, we have headphones, and we have gloves. And one of the things that people don't realize about dementia is it impacts how your brain interprets the world around you. So, for instance, in talking about sight, there's nothing really wrong with your eyes necessarily as a result of dementia. What's going on is that your brain is struggling to interpret what your eyes see. So that's what we're simulating. There are also changes to taste and smell when you have dementia. We don't simulate those because I always say we'd get a bad Yelp review if we tried to do something weird like that. So we stick with the 3 senses, and we show people how those sensory changes happen. Most people think of dementia as just memory loss, and obviously that can be a part of it, but dementia is really a lot more than that, and it impacts your brain in a lot of different ways. So we try to show that this is not just about old people being forgetful. First of all, people can have dementia if they're not old, and it's about a lot more than people repeating the same stories or losing their memory.
Mm-hmm. When people go through this and have their awareness raised here, what is the most common reaction people have when they come out the other side of the dementia house, simulation house?
Yeah, that's a great question. So we actually have little wooden brains, and when people are done with the simulation, they're asked to write a word on that brain that reflects their experience as a person living with dementia.
Little wooden brains?
Tiny little wooden brains. We get them on Etsy.
Okay. I had to take a moment to picture that. Okay, I think I got it.
Yep. Nope, we get them on Etsy, so they're little wooden slips like on the shape of a brain.
Got it.
And people use a marker, and a lot of words, some of the words that people write, they write isolating, slow, overwhelmed, overstimulated, confusing, frustrating. Those are some of the more common words that we see. Among those who are caregivers, whether they're professional caregivers or they're family caregivers, a common response is that they really did not understand the experience of the person living with dementia, and in response to that, they feel empowered to change how they interact with that person to make them more successful.
Wonderful. Let's connect this with the themes that you had in your TEDx talk on anxiety and dementia, because I had a similar experience in watching those 15 minutes that you can find online on YouTube in that as well. That years I've had, people in my circle of friends, loved ones with dementia. And that, I thought, okay, I understand this, anxiety and dementia, but I found that I didn't. So let's dig into, or at least all the facets of it, let's dig into that. At one level, being diagnosed with dementia is something that induces anxiety, for sure. But that's not all we're talking about, right?
Yeah, so there's a lot of links that people don't realize between anxiety and dementia. And this is something, this part I did not get into in my TED Talk, but untreated anxiety throughout the lifespan increases your risk of dementia. So there's that link there. So it's another reason to take care of your mental health. The same thing is actually true of depression or PTSD. So people who have lifelong anxiety, they're more likely to develop dementia. But in addition, like you said, getting that diagnosis is scary. But dementia also changes the brain in a way that makes people more prone to anxiety. And in addition, I want to point out, and this is true for all of us, that emotion lasts longer than cognition. So what I mean by that is when you start an interaction with someone who has dementia in a way that provokes anxiety, which many of us do by the way we approach people. When we spike that anxiety stays, even if the person has forgotten why they were anxious. So it's really important to try to keep that level of anxiety as low as possible, because when anxiety goes up, cognition goes down. Again, true for all of us. If you think about test anxiety, many of us have test anxiety and we don't do well on the test. But what we do with people living with dementia is oftentimes our behavior causes them anxiety. They may have pre-existing anxiety, but the higher their anxiety is, the more they struggle with cognition. And they may struggle with cognition anyway. So when anxiety goes up, cognition goes down. And that's one thing I think is important for families to realize, is that the brain of someone living with dementia, or all of our brains, are going to work better when we try to reduce anxiety.
If you just joined us, Elaine Eshbaugh is with us, professor of gerontology at the University of Northern Iowa, talking this portion of the program about the connection between anxiety and dementia. One part of your TED Talk that really brought it home to me, and I'd like you to spin it out for us here, because you have these, what you called mental pennies.
Yes.
That was so good, because it's like, okay, every day you wake up with, I think your example was you have 100 mental pennies if you slept well. And then that's what you have. And by interacting with someone in a certain way, you can have them spend fewer mental pennies. So talk a little bit more about that.
Yes. So I work with this concept called mental energy pennies. And like you said, on maybe a perfect day, I would wake up with 100 mental energy pennies in the morning, just, well rested and raring to go. And I mean, that's not typical for a human being. I don't think anyone is fully charged ever. But let's say hypothetically, I wake up in the morning and I have 100 mental energy pennies, and things I do throughout the day will cost me mental energy pennies. So being on this show, I'm using my brain. I'm engaging in this. So it is a positive thing, and it's going to cost me mental energy pennies. Negative things are also going to cost me mental energy pennies. Like if I get in an argument with my spouse, that's costly as well. But if you think about someone living with dementia, as the condition progresses, they may wake up and they may have 50 or 40 or 30, even when they're totally recharged. And everything is going to be more costly for the dementia brain. So something that we think of as a daily task that requires really no effort. So let's give an example of brushing your teeth. Someone with dementia may have to spend their mental energy pennies to get through that process. So first of all, they have to find the bathroom. And I have people living with dementia who wake up in their own homes and they don't remember where the bathroom is, and it's an unfamiliar environment. So that may in itself cost them mental energy pennies. Finding the toothbrush, putting the toothpaste on the toothbrush. All of these steps are a little bit more costly to that dementia brain as dementia progresses. So sometimes the dementia brain is really tired and it's out of mental energy pennies. And I always ask people who don't have dementia, how do you act when you're out of mental energy pennies?
Yeah.
And
Get
I
away
get
from me.
responses like,
I don't want to interact with
yes,
you, right?
Exactly. So we have people who kind of have an outburst when they're out of mental energy pennies. You're right. Get away from me. Leave me alone. We have people who withdraw, but no one is at their best when they're out of mental energy pennies. And, no one wants to be around you when you're out of mental energy pennies. You're just not that pleasant. The same is true for those living with dementia. But we often don't recognize they're out of mental energy pennies because we don't realize things are so costly to them. So an example we use a lot is like a family holiday. So someone with dementia at a family holiday, there's a lot of commotion. It can be really stressful and exhausting for that dementia brain. But then grandpa snaps at the kids and everybody's like, well, what's his problem? Well, his brain is exhausted. And maybe family holiday, you used to go for 8 hours. It was a whole day thing. Maybe now that grandpa has dementia, maybe you go for an hour and a half and you leave before he's out of mental energy pennies.
Yeah. Hit that sweet spot and don't exhaust the mental energy pennies. Give us some common, well-intentioned mistakes that families make that can actually increase a loved one's anxiety.
So we approach people who are living with dementia in a way that sometimes automatically spikes that anxiety. So first of all, one thing people don't realize about dementia is as it progresses, it often will impact your peripheral vision. So we're talking about side to side, of course, but people also don't think that's up and down as well. So you kind of have narrow tunnel vision as dementia progresses. So just a very simple thing that we do that we're well intentioned is we approach people who have dementia maybe from the side or from the back. We approach from the side, or maybe we put their arm around them and we touch them before they can see who's touching them. And that, I always say, that automatically spikes anxiety in most people when someone touches you before you know who they are or that they're there.
Yeah, what's that?
But it's really right. It's really easy to do that with people living with dementia because of the visual changes and sometimes the lack of awareness, of their surroundings. Another thing that can increase anxiety is when you have someone living with dementia and you're trying to have a conversation with them and they're trying really, really hard to pay attention to this conversation and engage, and their brain has to work harder than maybe we realize. We need to think about minimizing other stimuli. So that means things like turn off the TV. It might be even something like visual stimuli that can be distracting for them. So maybe the window's open and they see cars outside. That can be distracting them from a conversation. And as their mental energy pennies decrease and they're trying really hard to pay attention to this conversation, they're no longer successful and they start to get anxious about that because they're struggling in that interaction.
Yeah. I had an experience, this is a good 10 years ago, and I didn't know really that my reaction was good. I think it was. You can tell me here because I wasn't as versed in dementia. I ran into someone in the community who I'd seen off and on in the supermarket, and I could tell on his face he recognized me, but then there was something that gave me a sense of worry in his face, and so I went up to him and I said, "Hi, I'm Ben Kiefer. Nice to see you again." And his immediate reaction was, "Hi, nice to see you, Ben. And thank you so much for reminding me who you are." So that's one of the
beautiful.
tips,
That's
right?
perfect.
That's perfect.
That's perfect.
I didn't know what I was doing, but okay.
I should hire you to teach a class. No, that's beautiful. So one thing that we oftentimes do with people living with dementia is we pop quiz them. And most of us don't like pop quizzes.
Yep.
So it's Ben, do you know who I am? Or Grandma, do you know who I am?
Don't do that.
Now the problem, exactly. The problem with saying, do you know who I am, is what you're really saying is, you should know who I am. And when they don't know who you are and you're asking that, they feel a sense of shame. Their brain is working really hard to come up with something, and maybe there's just nothing there. Oftentimes after that, we want to give them clues. So it would be like, well, okay, so I'm your granddaughter, and I'm the one who's married. I live in Wisconsin. It might be something like that. And in the end, maybe Grandma does know, oh, I know who you are. But how many mental energy pennies did it take for her to get there? And then you're going to ask her to have a conversation, and she's just got less in the bank because you made her use her mental energy pennies just to in that initial interaction to figure out who you are. So, in talking about things that increase anxiety, the do you know who I am is always going to increase anxiety. Also, I want to take the question, do you remember, out of our vocabulary for people living with dementia. And that's simply because when we ask someone, do you remember, what we're really saying is, you should remember this. Mm-hmm. And when they can't, it's very frustrating. It's very anxiety provoking. So one thing I always tell people is, if you want to reminisce, and we like the term reminisce for people living with dementia, say, I remember. I remember when we went to Minnesota and we had that weekend on the lake, and I remember we all went out for ice cream. And maybe your loved one is going to jump in because they remember something, and maybe they're not. And that's okay too, but you're not putting them on the spot and asking for information that may not, it just isn't available to them at the time.
Right. We have 1 minute left. I want to make sure we note that you're active in dementia-friendly Iowa. So many aspects we could talk about there, but in the final minute, where can people go to learn more or connect with resources like Dementia-Friendly Iowa?
So if you go to our website, which is if you look up UNI Dementia Simulation House, there are other people who do simulation, but we're the only people who do it in a house setting. So Dementia Simulation House, you'll find us and you'll find some resources there. We have some online resources for families. You can book a time to come see us. We also do cognitive screenings. In addition, you can go to Dementia Friendly Iowa, and there are Dementia Friends trainings across the state. We do them here. We do them on Zoom, but other people across the state are doing them as well. And we have educated, I think now about 20,000 dementia friends across the state, and I'm really proud of that.
Really wonderful work. Thank you so much, Elaine.
My pleasure.
Eshbaugh, professor of gerontology at the University of Northern Iowa. And again, to get you connected with that, you look online for UNI Dementia Simulation House or Dementia Friendly Iowa. Take care. Thanks for coming into the studio, Elaine.
Thank you so much.
Today's program produced by Danny Gear. Help from Nev Kelly. I'm Ben Kiefer. Thanks for joining us.